The next topic, and we have Dr. Pavari joining us, is going to be moving from the intracranial to the extracranial and looking at carotid artery disease. And I've often said that if all I had to do every day was see patients with carotid stenosis, I would be a very happy neurologist. So this is a topic that I am very excited to hear about. Let me introduce our speakers. Dr. Auyang, Dr. Philip Auyang is a board-eligible vascular surgeon who did his medical school at Case Western and then joined his residency and fellowship here at Houston Methodist. Dr. Auyang does both endovascular and open vascular procedures, which I think that means you can fix the mistakes that you create. Is that what open does?
That's our calling card.
And we're also joined by Dr. Charu Pavari. Dr. Pavari also did his training here at Houston Methodist and has been a real, a pioneer, someone who's tested out a lot of novel techniques in both robotics and brought really TCAR to our institution and has been a leader nationally in the TCAR development. So with that, I'll just say that as we think about this debate, instead of just being generic about what is better or what's the superior technique, I'd like to think of a patient. So I'd like you all to come here prepared to think of a 70-year-old woman, asymptomatic, but has an 80% carotid stenosis that's heavily calcified. And if that patient were sitting in front of us and asking us, what would you choose and why, what would be the advantages or disadvantages to treating that heavily calcified 80% lesion with a endarterectomy or with a TCAR. So I'll turn it over to Dr. Auyang.
Hi. All right. Thank you, Dr. Volpe. My name's Philip Auyang, and I was a trainee here, and thankfully now I'm board certified, not just board eligible. I should have updated that. So I'm going to be talking about carotid endarterectomy and, of course, going over the history and background of carotid endarterectomy, as well as all the published outcomes that have been coming out over the many years since it's been indicted, and the evolution of patient selection for cerebral vascular interventions, the present-day dichotomy of extracranial carotid treatments, and the role of treatment modalities present and future. So just a little bit of background, 87% of stroke etiology is ischemic, 7 to 18% of all ischemic strokes are due to extracranial carotid disease. This would equate to approximately 56,000 to 144,000 extracranial carotid artery-related new and recurrent strokes annually in the US alone, so clearly significant. And these strokes are related to extracranial carotid disease, and they're usually either hypoperfusion or embolic, which is an important distinction that I think that we don't stress enough. The origin of carotid endarterectomy, of course, we have to come back to our history here. The first reported carotid thromboendarterectomy was performed by Michael DeBakey here in 1953, but the first published report was by Eastcott in 1954. The picture labeled in B here is kind of the more traditional way where you gain exposure of the common, the external, the internal. You do a longitudinal incision, you physically remove the plaque and you patch it either with bovine or vein and to prevent restenosis. The other less known way to perform this surgery is called the eversion technique, where you actually transect the internal carotid artery, you evert it, you remove the plaque that way, and you resew it. You don't need to use any prosthetic in that instance. So what are the advantages and disadvantages? That's what we're here about. Of course, there's direct exposure of the internal, external, and common carotid arteries. You can clamp the arteries, and the emboli cannot physically travel to the brain, which is very important. And again, physical removal of the plaque and the thrombus, rather than using a stent that just kind of pushes the plaque to the side. But what are the disadvantages? Everything has a disadvantage. I'm not going to say here that carotid's the best thing for everybody, even though that's what we want to say. Cranial nerve injuries, first and foremost, are the most common. There's also iatrogenic dissections from clamp injury or even putting in shunts. If we elect to put shunts in, you can cause dissections that way into the internal carotid artery. And of course, if there's a reoperative field, radiation or high bifurcation of the disease, which increases the complexity of disease and exposure. Just to give some clinical background or clinical significance to the cranial nerve injury, I know this is a busy slide, but you can see this is where we're usually exposing and the nerves and how closely related they are. But most significantly, the vagus nerve and the hypoglossal nerve. And the hypoglossal nerve, you see, is probably the most likely or most commonly injured, and that can result in ipsilateral tongue deviation, which is the tongue towards the side of the injury, and the vagus can cause hoarseness. Another that we can see is marginal mandibular, which is usually a transient deficit, and that's just from retraction, but can be confused with post-op stroke, but it's usually ipsilateral lip drooping. And then the main difference is general anesthetic versus local anesthetic. Now, carotid endarterectomy can be performed both ways, but generally most people do this under general anesthesia, of course with the risk of MI and death in that instance, but they can be performed under monitored anesthesia care with local, but this is often very difficult, especially if the patients stay still. So now I'm going to discuss the literature, and of course I'd be remiss if I didn't discuss ACAS and NACID. So ACAS trial was published in 1995 in the Journal of American Association. It was a randomized controlled trial of 1,662 patients of greater than 60% asymptomatic stenosis. So going back to Dr. Volpe's original question, based on this study, they would have said, yes, absolutely, you should get a carotid endarterectomy. This was a follow-up of 2.7 years, and a 5-year Kaplan-Meier projected risk for any stroke and death was 11% in the medical versus 5.1% in carotid endarterectomy. And so, but however, there wasn't any statistical difference until after 5 years. So if the patient didn't have a life expectancy over 5 years, even this paper from 95 would say that it may not have actual benefit. But of course, the main downside for these papers is the medical therapy. This was in 95, and the only medical therapy these patients had was aspirin at the time. In the NACID trial in 98, published in New England Journal of Medicine, 2,000 patients, mean follow-up of 5 years. Their primary endpoint was stroke and death for medical management versus carotid endarterectomy. However, these were in symptomatic patients of greater than 50% stenosis. These patients received aspirin, antihypertension medications, and statin. However, the surgical results, the carotid endarterectomy, perioperative stroke, and death rate was 6.5%, and for disabling stroke was 2%. However, the 2-year ipsilateral stroke rate was 26% in the medical arm and 9% in the carotid endarterectomy arm. However, this was specifically for the greater than 70% stenosis group. And so the overall mortality was higher in the medical treated group, but not statistically significant. But this was very eye-opening at the time, and this is kind of what really set the stage for carotid interventions for years to come. These traditional indications of the studies, that were adopted were in asymptomatic patients greater than 60% stenosis and symptomatic patients greater than 50. However, again, the primary criticism was the lack of lipid-lowering agents, antihypertensive agents, and antithrombotic or antiplatelet agents. How about let's move into the contemporary world. So the CREST study in 2010, published in New England Journal, 25,000 patients, symptomatic versus asymptomatic, for patients undergoing carotid endarterectomy, and now transfemoral stenting is coming into the stage. They did not find a significant difference in estimated 4-year rates of stroke, MI, and death as a composite. But the 4-year stroke or death rate was 6.4% in the stenting group and 4.7% in the carotid endarterectomy group. And this was even more significant in the symptomatic arm, which was 8% in the stenting group and 6.4% in the carotid endarterectomy group. But they did see more periprocedural MIs in the carotid endarterectomy group, 2.3 versus 1.1% in the stents. But periprocedural strokes was higher in the stenting group, 4.1 versus 2.3 in the carotid endarterectomy. And one of the more recent trials, the ACST2, which was published in Lancet in 2021, was an international multi-center randomized controlled trial of 3,625 asymptomatic patients. This is comparing carotid stent versus carotid endarterectomy with a follow-up of 5 years. And they were a 1-to-1 stent to carotid endarterectomy group, and they selected them based on if they felt that they were deemed acceptable for either procedure. Now that in itself I feel like is a selection bias there. And these patients had over 60% stenosis on ultrasound. Both arms were considered good medical therapy. This was not really a study to compare medical therapy, but really to compare the two modalities. And they identified 1% disabling stroke and 2% non-disabling stroke, with no significant difference between the two. In the 5-year non-procedural stroke, carotid stenting was 5.3% versus carotid endarterectomy 4.5% without significant difference. And so with all this knowledge and this ever-growing knowledge base that we have, we've seen an evolution of patient selection, particularly in the realm of asymptomatic versus symptomatic disease. But with symptomatic, the highly contested area is how do we treat these symptomatics? In the CREST demonstrated that symptomatic patients had a higher peri-procedural stroke rate, 6% versus CEA, which is 3.2%. That was statistically significant. However, in the asymptomatic group, as we've been discussing all day, there needs to be more understanding, more literature to really understand is there a benefit in these patients, and this comes back to Dr. Volpe's question, if there's asymptomatic patient over 80%, do we need to intervene on this? And I think that there's still more literature needed for that. Another area is the degree of stenosis. So traditionally, asymptomatic patients would be treated for greater than 60%. However, over time and with more literature demonstrating low risk for stroke in asymptomatic patients, the trend has definitely progressed towards higher degree of stenosis thresholds. Nowadays, most people adopt the greater than 70%, but it has even been up to 80% has been proposed. And symptomatic patients remain high risk for recurrent stroke, and I still believe that greater than 50% people would benefit from treatment. However, I think the most important and very intriguing criteria is vulnerable plaque morphology. And this to be used to grade the carotid disease. However, this is very difficult to assess in a large scale using current imaging modalities. This could be used as a great guide to therapeutic options, stent versus CEA versus medical management. There is B-mode ultrasound, which can identify echographic parameters such as plaque surface irregularity, echolucency, and texture, which have been used to implement in a total plaque risk score, and these could be provided predictors of ischemic events. And I believe as imaging technology improves, there may be more value in investigating plaque morphology to determine type of carotid interventions. On the image here, you see this is a thin and disrupted fibrous cap. Other vulnerable plaque morphology includes large lipid-rich necrotic core, neovascular growth, and intraplaque hemorrhage, and these are all examples of the vulnerable plaque morphology. Now you look at this, and would you want to put a stent in that? I don't know. I don't think I would. And so, what is the dichotomy of treatments
even if you
today?
do, Philip, you don't want to see what happens after the stent is placed.
Exactly. Well, that's the main thing, right? It's what's out. We can put a stent in anyone, but what about afterwards? And what about the brain? So there's a definite trend towards less carotid endarterectomies since the post-CREST era. Cole queried the National Readmission Database to identify both asymptomatic and symptomatic patients undergoing stenting versus CEA between 2010 and 2015. In total, there was 378,000 carotid endarterectomies and 57,000 stents over the 6-year period. However, the carotid endarterectomy group, the volume was decreasing by an average of about 2,700 procedures annually, while the stenting group remained stable. And so what's the future, present and future? So medical management, I still believe there needs to be more data to determine the efficacy of medical management alone. Carotid endarterectomy is a tried and true that we've known for many years and has demonstrated acceptable risks in experienced hands. Less than 6% in symptomatic cases and less than 3% in asymptomatic cases. And then stenting, and there's transfemoral stenting, which has been studied, but now there's transcarotid stenting, which there has not been much literature at all about this. And with the advent of new protective devices, this may decrease stroke, but there's still a need for more data to prove efficacy over CEA. So although we all want to say carotid is the best, there's always room, and I think everything should be a case-by-case basis. And CEA remains the most well-studied treatment modality for extracranial carotid disease. Large-scale prospective data is needed to determine safety and efficacy for medical management stenting, especially TCAR. Different lesion types may help guide choice in treatment modalities, and improvements in imaging will help guide our ability to choose the best treatment. And of course, carotid endarterectomy is the primary modality of choice, but I do believe this is going to change over time. But I don't expect that carotid endarterectomy will be completely replaced by stenting or medical management therapy alone. I just have to refer back to this picture here.
Thank you, Philip.